To get us started will be Mike McCarthy from Indiana Spine Group. He will speak. He gave this talk last year, which was fantastic. It's utilizing navigation robotics early in your career for lumbar spine surgery. Mike.
As Mike said, I'm one of the partners here at ISG, and so we're talking about navigation and then robotics kind of early in practice. So a couple of disclosures. Some of these are relevant. I will be kind of referencing multiple different platforms today with robotics and navigation. Probably the biggest disclosure, I think, though, is when you start talking about navigation or new technology, you get these huge zealots. You get someone in the room who's like, this is all I do, and it's the latest and greatest. And so you get someone swinging over to one side and someone saying, okay, that's the worst idea in the world, and you should never do that. And it's kind of tough, I think, as a learner to really kind of garner an understanding as far as what should I do when I go into practice. And so hopefully I give you something a little bit more moderate, not too right, not too left. So for you guys, when you graduate from your residency or fellowship, this is how you feel. I mean, you walk in your first day of work and you feel like I am the man or the woman, and you are dancing, right? And you think you're the latest and greatest. And you look around and you look at spine surgeons that are near you, right? And you kind of look at some of your senior guys. You look at guys like Jason, who have models with his name on their shirts, right? And then you look at kind of the older guys, like the older generation, and then they're kind of weird because they like pose with dogs and stuff. So you can see Rick and Todd Albert posing with dogs. So, I think what's important is you're so excited to start your practice, and you look at all these people around you, and then you realize like, hey, look, I got to get started. And you kind of get lost and you get swept up in the motion of it, about technology and doing all these cool things like I'm the endoscopic guy or I'm the robot guy. But really what you want to focus on are the things that are pounded into your head now as residents and fellows. I like to call those the non-modifiable. So these are the things that don't change, right? This is the basic premises of why we are spine surgeons, what we provide to patients. And the problems they tend to come in with, again, don't change, but how we treat them do, right? And so the technology that we can kind of leverage and have at our disposal, I like to call them modifiable things. And that's what we're really talking about today. But you can't forget the basic tenets here. So where have we come? From a historical perspective, and we've really seen a huge kind of gamut as far as what we were using at about 10 years ago, even 15 years ago, to what we're doing today. I mean, just illumination, right? Lights above us, and then obviously lights in tubes, and now endoscopy. And you can see all the way from kind of navigation robotics to AR we're able to utilize in the OR, even to real-time assessment. So you feel like the future is here, and it's only continuing to expand, and we're getting all this cool stuff. So really, this is such a wonderful time, I think, to be in spine surgery. But why am I such a believer in this? I guess another disclosure is I'm a big MIS guy. I like to do a lot of MIS surgery. And I think personally that these platforms help me be a better MIS surgeon, and I think they're kind of imperative for the surgeries I perform. And you might disagree with that, but I think that this is really, really important to minimally invasive surgery. Additionally, it's a big regional trend. When I moved here, I was kind of blown away. I wasn't a huge navigation proponent when I first came here, but in this building alone, so in our ISG complex, we have 3 O-arms and 2 robots, right? So think about that. I mean, I don't know how big hospital system you go. You might have 1 O-arm or one robot, but it's really kind of a mind-blowing how much technology we have here. But that kind of spreads throughout the greater Indianapolis area. So there's more, kind of navigation units here per capita than anywhere else in the world. So again, I'm kind of saturated in it sitting in this market. So take that for what it is. But I think the overall opportunities that this stuff provides, whether it's streamlining processes in the ORs, placing screws, that decision fatigue is very real, and when you get started, you'll feel that. And I think this technology can kind of help mitigate that a little bit. Accurate planning, knowing where you are in a pedicle, how big can you upsize? You go 6.5, 7.5, 8.5 screws. Those are kind of cool things. But I think the biggest thing that this kind of offers, and I think which is really applicable to you guys, is this young surgeon jump, because you got to get out in the market and you got to compete against guys who are more your seniors, right? Guys have been doing it for 10, 15, 25 years, who can do a microdisc like no sweat off their back, right? In 30 minutes or 45 minutes, and you're like struggling in there, right? And there's blood everywhere and you don't know where you are. And so I think a lot of these things can really help you kind of bridge that chasm a little bit and give you that kind of experience quotient that you only can get with time, but maybe this technology can help you kind of close that gap a little bit sooner. So what does that look like? I think from a matching experience standpoint, this is what it can look like. So this is a busy OR. This is my OR. You can see I'm using navigation here. And it can get busy at times. You kind of almost think like you overdo it. And sometimes I think early on in my career, I probably did overdo it with the amount of technology that I would utilize in a case as far as trying to get things done. And this is a look you can get sometimes from senior partners when they walk in the room, like, what the hell are you doing? Why do you have all this crap in here, right? What are you doing? And I think as I've evolved, I've learned this stuff is really good, and I still use it, But you kind of have to really take it into consideration of what's the goals here. And, whether you kind of lean on your mentors like Wellington or Alpesh or Rick, right? Or even on the bottom, you take long romantic walks with your co-fellows. But it's kind of that merging of your ideas of what are you there for with the non-modifiable components that I kind of alluded to before. And how does that technology help you, right? You need to drive that technology. The technology shouldn't really drive you. And so it's really kind of bringing those together. So I'll get off my soapbox now as far as that and really kind of get into the meat of the conversation. And so when we talk about navigation, hopefully you guys have been exposed to this. I'd be kind of surprised. Has anyone not used navigation? Yeah, I think it's getting far and few between at this point. But really, this stuff was adopted out of intracranial uses, and this is some of the kind of the Sentinel paper in 1995 by Nolte that talked about that transition from intracranial uses now into the spine. And for you guys, just some basics. You can see here, kind of that on the left side here, that dynamic reference array, the navigation station itself, which is kind of the camera, the instruments with the fiduciaries that kind of show real time where is the instrument compared to the patient. And then kind of the image acquisition unit, whatever system you may use, is on that kind of far right. So how can you use this stuff? Well, there's a whole, I think, a broad array of reasons and different patients that you should use this for or can use this for. I think, complex anatomy situations, this is a lady I did a TLIF on in the middle of TLIF. I didn't get a preoperative CT, which is just not part of my algorithm. She had no pedicle on that one side. And so within seconds, I was easily kind of able to throw a cortical screw across without really having to think about it, right? Big patients, look at the bottom right-hand corner. That's our classic Indiana patient. I mean, shooting an X-ray to figure out whether your screw's in or out is tough in that size of a guy. Navigation can help you in that. Mitigating bad days in the OR, like the upper right-hand corners, you don't want those pictures showing up under your name, right? So those free-handed techniques, or even sometimes technology can lead you to places. But again, I think navigation can kind of help lower that rate of issues. And then obviously the kind of expanded capabilities of minimally invasive surgery, smaller incisions, less dissection, and doing things through kind of less invasive means. So the platforms, I'm not going to go through these. There's a lot of them. They continue to evolve, and different companies come out with different ones, so you don't need to memorize this. But what does NAV really offer? Well, I think if you drill down the literature, this is really what it provides: safety, efficiency, and then less radiation exposure. And so as you kind of comb through this, whether that on the top right, it's a randomized control trial. On the other left, you can see this comparative study. But essentially, they're showing, hey, look, when you compare this to freehand, clearly there's an advantage of less medial breaches, less issues with placement of screws. From an efficiency standpoint, clearly we're seeing faster OR times when you can master this technology. You can see that you can more quickly and efficiently place screws. And this is actually an old paper from Rick from 2007, which kind of almost, a lot of technology comes in front of us, right? And you'll see these waves like, oh my God, the latest and greatest is this. And then you kind of see it fizzle out. And Rick kind of nailed it on the head when he talked about, hey, look, navigation's kind of here to stay. Like, this is a big deal, and this can really make, precision and accuracy and safety really a big component of our surgery with this platform. The radiation thing is that what I'm a big proponent of, and thinking about, what that can provide to you as a surgeon and your team, and then also the patient. And I think clearly the literature has shown us that we're seeing significant reductions in radiation. And I think that is really where I hang my hat. When people ask me, like, why do I do this? Well, that's probably one of the big components here. And you can see it right here. This is a TLIF that I did in fellowship. And I went back and we filmed the fluoroscopy. And you can just see how many shots we took. It's wild, right? And this is actually a paper that came out with Shiraz Qureshi, where they talked about mastery of an MIS TLIF using fluoroscope. And essentially, like, okay, if you can get from 2.9 to 2.1, you've mastered an MIS TLIF when you think about radiation exposure. But if you stop and think about it, you're still exposing to 2 minutes of radiation. That's still wild, right? That's not a mastery of that. I mean, that's something you really have to think about for you and the patient. In lateral surgery, think how many shots you're taking with an O-lift, even with an A-lift, right? You're taking a lot of x-rays. So how does navigation kind of stop that or at least decrease that exposure? I can tell you personally, it really helps with a workflow from an efficiency standpoint. Once you have navigation in place, I don't have a C-arm in my field. And you can see that's me and a fellow placing screws. I don't have some bulky C-arm saying, oh God, am I in, am I out? Do I have to check it, do I not? I know real time where I am. One of the kind of big contentions, I think, with this technology is in a learner kind of environment when you have trainees. And people will say, well, it's terrible for trainees. And I would adamantly argue against that. And I think that this gives you the best real-time environment for learning. That if I'm able to say, hey, look, don't look at the screen. Show me where you're going to put that screw. You drill, you tap, and I say, stop. Look at where you're at. Do you like that? that is real-time feedback. You can't get that under freehand techniques, right? So again, I think for trainees and stuff, this only kind of augments your education. And then obviously the clear knowns, optimizing screw trajectories. S1 screws, mine are straight up into the promontory every single time, and I can punch through and really get excellent fixation. So those are all kind of, I think, the advantages of it. From a workflow perspective, you can see here, I'll kind of fast forward this. But again, this is the big knock, right? It takes too long to use navigation. And I would, again, argue against that. I don't. This is a very standard case. I didn't even tell, this is one of my partners, Jeff, I said, I wasn't even going to tell him I filmed this. I said, I'm going to be in here. And I put my phone up there without him knowing this, right? And I filmed this, and it's 4 minutes, right? And this is kind of, I would say, on the longer end of the spectrum as far as spins. But you can see clearly, he's putting the array in. He parks on the PSIS. You can see we're going to sterilely drape the patient. I don't think this player wants to play, but you can see kind of through this video that the arm comes in, clamps, we get the spin, it's out, and within 4 minutes and 41 seconds, he's already putting screws in, right? So clearly, I tend to disagree with that, that it takes too long. This is the workflow. I think from an efficiency standpoint, this is my MI's TLIF. I mean, this is what I drill into the fellows, so they know this from day one. This is exactly the steps we will perform because I know exactly. There's no questions like, well, what happens if we have a medial breach? What happens if I think the pedicle screws out? Well, crap, we got to bring the C-arm back in, right? That's out of the game, right? We have backup plans, but we can clearly follow this efficiency. So again, the big gripe is image acquisition, and people kind of act like this is one of the Apollo missions, getting the lunar module on the moon, and it's not. And I think this is you kind of being a leader in the surgeon and getting your team, right? When you can get your team members and say, hey, look, everyone, let's get on the same page. This is how we're going to do this. This becomes a no-brainer and becomes part of the second hand. It's just like all the kind of nuances that you have ready in the OR that the nurse may get ready for you. You just have a couple more people now who are ready for you. The ORM's outside the room as soon as the patient's flipped, right? You know when the sterile drapes come on that we're going to get the ORM in. So getting people clued in. So I'm going to transition outside of navigation now into kind of the different platform robotics. And again, huge kind of a swath of options for you when you come into practice and you want one of these. You can see kind of, this is actually the earliest iteration, the Mazor Renaissance system, the bottom left-hand corner. So again, lots at your fingertips. But when you talk about robots and you go into your first job, it's usually not like, oh, I'm the robot guy. It's usually an administrator looking at you going, what the hell? This thing's $1 million. You want this, and why do you need this? Because the other guys don't need this, right? And you need to be able to really kind of talk about this and have a good reason why you want this. And hopefully I can kind of give you some of that info. But I think that is what slaps you in the face, the first thing. And there's creative ways that companies have kind of structured plans with implant expenditure and things like that to kind of help offset that and mitigate that. But at the same time, it's an expensive product. But I think those long-term kind of cost savings are real. We've seen that come out in the literature too. I wouldn't necessarily say like that's the reason why I use robotics, but I think there's some real data that speaks to that. So what are some of the advantages? Well, I think similar to the navigation platform, that reduction in radiation. I think that automation as far as placing screws, if any of you guys have used this, it becomes very sequential, especially in a little bit of a longer construct. It's just boom, boom, boom. It's almost like it's a machine work, very quickly and precisely placing screws. And then complication avoidance. So those days that you can really plan these screws out and try to avoid those issues. So what does the literature say? So this is a really important study. It's a multi-center prospective study by Mike Wang with the MIS Refresh study, and they compared robotics versus freehand. And essentially, this was kind of a big known at the time, but we really wanted to prove it. And you can clearly see that about 11 times lower risk of revision surgery and almost a 6 times lower risk for surgical complications, clearly favoring robotically placed screws versus freehand. But again, that's not a fair comparison, I think. So what about if you compared navigation versus this? And that gets tough because a lot of these systems have really kind of merged and become one. But this is a retrospective study looking at both nav and robotic, and you can clearly see accuracy and precision were roughly the same. But for you guys who have used this, one of the unique advantages of robotics is you can plan your screws. So a lot of us, for you orthopods who have sat up at night and templating your hips and trying to figure out what size you need for these things, this is kind of like that. You can sit there and really say, hey, how big a screw can I get in this pedicle? And then put it in very quickly. Inner body is the same way. I can kind of use that platform to really kind of size up my inner body, my correction, even with some of the newer software. So a lot of cool things that you can do from a planning capabilities. But what's the hang up? Why aren't more people using this? Because clearly, I'm sure most of you walk by the robot in your OR and it's just collecting dust. And maybe someone is using it. But I think the big thing that you're going to encounter is the learning curve. It's high. And I think getting your team on board is tough, especially your first couple of cases. And this is a study out of Germany where they essentially said, how can you kind of get going? You're not even at an expert level, but how can you at least be somewhat, average? And they say about 25 cases should be performed with an expert before you're really kind of off to the races. So that's kind of hard, right? Especially early in practice. You're asking your partner to come scrub 25 cases with you. He's going to tell you to screw off at some point. And so the learning curve is somewhat steep, and I think it takes time, right? I to this day, I still probably, if I rev up my team as fast as possible, I can probably match my navigation time when I compare it to robot. And again, people get frustrated, and if you're taking more time, there's a financial incentive in the OR. So you got to get buy-in. You got to kind of say, look, I'm going to do this and really kind of push this forward and get to that spot that you want to be in. So why do I use this? If I'm kind of dogging a little bit, I think the planning capabilities are really wonderful with this platform. The screw, pedicle fill, screw size, optimizing your construct is really what this allows you to do. And then for young surgeons, I think it offers you a little bit of a crutch in the OR for those complex cases where maybe there's some distorted anatomy things. You're like, what the hell is going on here? It can kind of add to that and be a helpful tool. As we talked about the cons, they're there. Learning curves, capital expenditure. There's some issues with it. It's not where we want it to be. So where do we hope for it to go? Well, I think we've seen that marriage of nav and robotics really come to light, and I think that's really helped move it along. But I think we all kind of hope for that dream world of robotics doing autonomous features. Essentially us allowing to click a screen and kind of babysit it a little bit, but it's doing its own thing on one side while we're doing something on the other. So what are the take-home points? I think probably the biggest thing for you guys as young surgeons is know where you're going. Don't evolve into something you don't want to be, right? It's kind of sometimes you see, as I showed that slide about the zealots of who's screaming about technology. You don't want to be the tail wagging the dog on this. So don't lose sight of these, why you're here, why you're doing this, why you're treating these patients. We've come a long way, and use this technology to make you a better surgeon.